Good morning, everyone. I'm going to talk about uh, obviously a pretty well-known topic, but I'm just going to present it in a slightly different angle. So I don't have any relevant disclosures for this talk, and this is my outline. So I'm going to talk a little bit about epidemiology and risk stratification in type 2 diabetes very briefly. Then I'm going to go over some old data and some new data in risk reduction in diabetic kidney disease. And then I'm also going to talk about risk reduction in heart failure. And then I'm going to present my version of how we could possibly integrate the two rather than operate in two different silos. Okay, so as everyone's aware, there's a substantial overlap in these conditions like chronic kidney disease, heart failure, type 2 diabetes, and atherosclerotic cardiovascular disease. And each one of them contributes to each other. And if you look at costs, it's a substantial cost to the healthcare system. The latest number I heard was that diabetes accounts for over $330 billion in healthcare expenditure, of which around 33 billion is spent just on diabetic medications. So I think it is important that everyone know how to manage this regardless of what they're doing in at least at a primary care level or internal medicine level. What's interesting is that, always we've talked about CKD as a risk factor for kidney disease. And we do know that the risk of cardiovascular death goes up dramatically as the GFR goes down. But what's sort of less advertised is the risk of cardiovascular disease with albuminuria. So just a increase in urine albumin over 300 increases the risk of cardiovascular disease over 3 times. So in a way, albuminuria is as good as a risk marker of cardiovascular disease as anything else. And if you look at heart failure, the similar relationship applies. So whether you look at worsening CKD or you look at urine albuminuria as just a marker of heart failure, there's a dramatic increase in incidence of heart failure just with what we would consider sort of slightly increased urine albumins. And this begs the question that everyone is aware of this KDIGO heat map, which stratifies CKD into different stages based on the GFR and the albuminuria. And based on that, they're classified as low risk, moderate risk, high risk, or very high risk. And the question here is this just for predicting risk of kidney disease, or can this map actually be used as a risk stratification for cardiovascular disease? Like, should this be used to decide who gets what type of treatment to reduce the risk of cardiovascular disease also? This is an interesting recent study that I found that shows that the incidence of chronic kidney disease, whether you look at just type 2 diabetics or you look even at pre-diabetics, and they classified something as high risk pre-diabetes, which was uncontrolled blood pressure, which they defined as systolic more than 148, uh, and then high cholesterol, which they defined as treated non-HDL cholesterol more than 130, or high CRP. And that by itself over time leads to a significant increase in the risk of chronic kidney disease. And as you can see, it doesn't matter what the A1C is, there is a sort of a linear relationship, if you were to say that even if people have well-controlled diabetes, they still have a significant risk of developing chronic kidney disease over time. The other interesting thing is that if you compare the risk of atherosclerotic cardiovascular disease between diabetics and high-risk pre-diabetics, and you follow them for a prolonged period of time, the risk is almost identical. And the same thing applies to heart failure. So, traditionally we would think that, if the diabetes is controlled, we've reduced the risk or they don't have as much risk as a pre-diabetic. But I think this study makes you think differently that maybe we should be intervening at the pre-diabetic stage even more aggressively than what is recommended right now. So moving on to risk reduction in diabetic kidney disease, we know there's various factors that drive chronic kidney disease and type 2 diabetes, uh, whether it's hemodynamic factors, whether it's inflammation, whether it's poor glycemic control. Ultimately, they all lead to structural changes in the kidney, which are manifested on a biopsy as glomerular hypertrophy, mesangial expansion, glomerular sclerosis, and ultimately interstitial damage, and which ultimately leads to fibrosis and CKD progression. So the other thing that's changing is sort of the epidemiology of the trajectory of kidney function decline in diabetic kidney disease. Classically, we said that patients first develop worsening albuminuria, and once they get what would be called as severely increased albuminuria, then they develop gradually worsening kidney function. But we know that a substantial number of those patients that actually have microalbuminuria, they actually sort of go back to the low risk category on their own, whether they're treated or not. And that practice of like screening for microalbuminuria is still there, but the data supporting treating that has always been weak because of this phenomenon that a lot of patients actually sort of regress on their own without treatment. Then we do have the other population that just goes downhill very quickly. And, it's recommended that biopsy those patients, but ultimately, uh, majority of those patients that you biopsy who have diabetic kidney disease still end up having diabetes, even if the trajectory is atypical, so to say. But this is not so atypical anymore. The other category, which is sort of less focused on, is the non-proteinuric or non-albuminuric diabetic kidney disease, those patients that never develop heavy proteinuria and still develop worsening kidney disease. The question here is that we don't really know if their risk is eventually much lower, or they are just a different phenotype. Now, for for at least for 2 decades almost, the sort of the mainstay of treatment for diabetic kidney disease was just ACE or like ACE inhibitors or ARBs, and nothing else. We didn't have anything else. But as you can see in the two major studies, there was a substantial residual risk of progression to ESRD that remained despite these therapies. And that's why once these SGLT2 inhibitor initial CV outcome trials came out, that was like sort of like, oh my God, this might be a game changer. What's interesting is that in the initial trials that were done, they were not really meant for studying diabetic kidney disease. They were just to prove cardiovascular safety as per the FDA mandate. So we had three major trials, the EMPEREC, Canvas, Declare, and these are all sort of several years old now, but remarkably, all three of them showed a reduction in composite renal outcomes. And in addition to that, they showed a consistent reduction in heart failure. And in at least two of these three studies, it showed a reduction in major adverse cardiovascular outcomes. The difference in the DECLARE trial was that it was not just patients with high risk features, but it also included patients who were given these drugs sort of after a cardiovascular event. So it was almost secondary prevention rather than primary prevention. So if you look further into these trials, you'll find that the patients who actually had CKD, so GFR less than 30 or albuminuria, they derived the most benefit in the cardiovascular outcomes. So that again begs the question, does the albuminuria serve as an important risk marker of cardiovascular disease? And can you use that to risk stratify patients and offer them more therapies to intensify risk reduction? And if you look, the risk was higher in the patients who had CKD, whether it was defined as uh, GFR less than 60 or albuminuria more than 30. But if you had both, you had a substantially increased risk. But those were the patients that benefited the most. So the most substantial reduction with dapagliflozin in this trial was in the patients who had the highest risk if we were to stratify them based on the KDIGO heat map, so to say. But still, these trials, like from a nephrology perspective, they were in patients who are very low renal risk. So they would all fall in this category in the heat map. Their mean GFRs were all normal. They basically didn't have any protein. So these are the patients that don't come to a nephrology clinic. So, but these are important because this may be the patients that are seen in primary care, and you could argue that these trials sort of justify primary prevention of diabetic kidney disease because, I mean, ultimately, people are going to have some GFR when they present. It's not going to be higher than any of these categories. And you can quantify the risk using the kidney failure risk equation. So if you use the EMPA-REG outcome trial, their 5-year risk of developing ESRD was basically negligible. So the argument was these are not applicable to the nephrology population. And that's why the subsequent two studies were absolutely game changers, because now we have two big trials in the population that actually comes to the nephrology clinic. And now there's a third one. So just to sort of review the big inclusion criteria of these trials, the Credence trial enrolled patients with increased albumin more than 300 with GFRs 30 to 90. DAPA CKD took it down to 25 and enrolled patients with albumin more than 200. And EMPA kidney has a slightly different patient population, which is important because it also includes patients who are stage 3B or stage 4 CKD without proteinuria. So that's the other section of diabetic kidney disease, which has never really been studied because it was thought to be sort of not high risk. But we do see that the epidemiology has changed a lot, so this becomes important. And I don't know if you're aware, but last week, the EMPA kidney trial was stopped because of efficacy. So it's again going to be a positive trial, and probably we'll have results presented in a couple of months. To go more granular into Credence and DAPA, they had roughly a gram of proteinuria. The GFR was 56 if you look at means in the Credence trial, and DAPA was even lower at 43. Obviously, the difference in the DAPA CKD trial was that not everyone was diabetic. It also included patients who were non-diabetic. Practically everyone was on an RAS inhibitor, and the blood pressures were relatively well controlled. If I were to put these mean numbers into the kidney failure risk equation, the Credence trial risk of development of ESRD is around 3 to 4%, versus DAPA CKD is pretty high at around 10%. So these are patients who are pretty high risk of developing ESRD. And we all know this, that both these trials were hugely positive, with the composite renal outcome in the Credence trial being with a hazard ratio of 0.7 and in DAPA CKD of 0.61. So it's pretty remarkable that this trial's been published less than 2 years ago, but we already consider SGLT2 inhibitors as standard of care now for diabetic kidney disease. Now, we've sort of covered this area. We are saying that Credence DAPA CKD covers this area. I'm extrapolating from the DECLARE trial that this area is also covered because, as I mentioned, the patients who had albumins more than 30 and the patients who had GFRs less than 60 in the DECLARE trial actually derived even more benefit. So this area is also covered. And this is going to be covered by EMPA. kidney, and if that trial is also positive, so practically this whole heat map is covered, suggesting there is no reason why, like you have to justify why somebody is not on an SGLT2 inhibitor and you're labeling them as diabetic kidney disease at this point. The one area that remains is the GFR less than 30 range, though DAPA-CKD goes to 25 and EMPA-KIDNEY now going to 20. So it's going to be just the patients who have a GFR less than 20 who will not be eligible for an SGLT2 inhibitor. And you could argue that they're already at ESRD. So the chances of benefit there are minimal, but they might still derive benefit from cardiovascular protection. We don't know that because no trial has enrolled that population. A word about GLP-1 receptor antagonists, because I don't really talk a lot about them. So they have been studied similarly as SGLT2 inhibitors in the low-risk population, so not in the high-risk renal population. And they did show significant benefits on cardiovascular outcomes, especially certain trials like the LEADER trial and the SUSTAIN-6 and the REWIND trial. What's interesting is when you look at the renal outcomes, they don't really show a benefit consistently on GFR loss. And if you divide the other composite outcomes as containing albuminuria or not containing albuminuria, so they do show benefit in reducing albuminuria. But if you exclude albuminuria as an outcome, then the composite outcome doesn't show benefit. As you're aware, there's another study ongoing with the GLP-1 receptor antagonist called the FLOW study, which is enrolling the high-risk CKD population, and that's going to come out in a couple of years probably. Now, what about combining both of these things? There's no trial that's actually looked at that, but what we have seen in post hoc analyses, for example, in the Canvas trial, that if you combine an SGLT2 inhibitor and a GLP-1 receptor antagonist, you do get sort of additional benefit. You do get additional weight loss. You do get additional blood pressure reduction. And the interesting thing is that the albuminuria didn't change much. So this part is not yet clear, but you will get other benefits. So you will get better diabetes control, better blood pressure control, better weight loss with the combination. And I think the most recent ADA guideline is recommending that combination can be considered in certain populations. Now, moving on beyond the SGLT2 inhibitors, there is enough data that mineralocorticoid receptor activation plays a role in heart and kidney disease. And that works mainly through inflammation and fibrosis, and it can cause kidney damage, vascular damage, as well as heart damage. And there have been prior studies with like mineralocorticoid receptor antagonists, but as we are aware, the standard or the steroidal mineralocorticoid receptor antagonists have had issues with incidence of hyperkalemia, and with the CKD population, that's always a higher risk. So that led to the development of novel non-steroidal mineralocorticoid receptor antagonists. The first big one of which is finerenone, which has now been studied in diabetic kidney disease. So the first trial was the Fidelity trial that was also published a couple of years ago now. And similar to like the other Credence and DAPA-CKD trial, this trial also enrolled patients who are relatively high risk for diabetic kidney disease. So either they had to have albuminuria and have retinopathy, like if they were in this, they had to have retinopathy, or they had to have severe albuminuria, and the GFR could be between 25 and 75. And without going into too much details here, because I'm going to talk about the other trial and then compare them, it did show a significant improvement in the kidney composite endpoint by 18%. One thing to note is that this trial was done sort of at the same time or just after SGLT2 inhibitors were being studied. So only 5% of patients in this trial were on SGLT2 inhibitors. When you look at the cardiovascular endpoint, it also showed a benefit. So the standard cardiovascular composite endpoint is the CV death, non-fatal MI, non-fatal stroke. And so finerenone in the Fidelity trial also showed benefit. Now, as I mentioned, there was two trials. So the second trial is called Figaro. And just to compare these two trials, so the GFR range was much wider in the Figaro trial, but the mean GFR is much higher. There were less patients with CKD as defined by eGFR in the Figaro trial, and there was sort of less albuminuria. So overall, the Figaro trial was mainly a cardiovascular trial versus Fidelio was mainly a renal outcome trial, but both of them studied the other outcome also. So in a way, to sort of put it another way, Fidelio enrolled high-risk patients from the kidney perspective, and Figaro enrolled lower risk. I wouldn't say very low risk, but lower risk patients. What's interesting is the large number of patients in both these trials, and that 100% of patients were on RAS inhibition at baseline. So this was add-on therapy, not replacement therapy. Now, Figaro, like I said, the primary endpoint in this trial was the CV composite, and it showed a relative risk reduction of 13%. The composite renal outcome was actually not statistically significant when they used the 40%, like they used a composite of kidney failure, reduction in GFR by 40%, or renal death. But again, we have to keep in mind that this population was at a lower risk for progression anyways. The fear is still that, oh, this drug is going to cause hyperkalemia. So there was more hyperkalemia with finerenone, but only 1% of the patients required discontinuation of the drug. So whatever hyperkalemia happened could be managed medically. And this is despite very low use of potassium binders. Like now, you can definitely use potassium binders in combination with all these drugs and further decrease the incidence of hyperkalemia. So when they look at a different outcome, so this is actually the outcome that DAPA CKD used, which is the 2 times creatinine or 57% decrease in GFR, then it does become statistically significant. But that's just, sort of a different outcome, but it is significant even in this low risk population. Then what they did is the investigators, they combined the data at a patient level, individual patient level, and did what they call as the fidelity analysis. So the fidelity analysis is a combined analysis of the Figaro data and the Fidelio data. And as you can see, when you sort of combine these two patient populations, you get practically everything that comes to the renal clinic. Like we don't get a lot of, maybe we're still not talking about the non-albuminuric kidney disease patients, but the rest of it is practically covered, at least up to a GFR of 25. And so in this, they looked at the CV composite and the renal composite, but in this, they used the 57% eGFR composite, not the 40%. The one thing I did forget to mention is that there were some exclusion criteria. So if your potassium at enrollment was more than 4.8, you were excluded. And they also excluded symptomatic patients with heart failure and reduced ejection fraction because mineralocorticoid receptor antagonists were already standard of care for that indication. If you look at sort of the distribution of patients, you can see that a lot of these categories are very well represented in this combined analysis. And the overall results are that the addition of finerenone to RAS inhibition leads to a reduction in the composite CV outcome by 14%, reduction in the renal outcome by 23%, and there is an increased risk of hyperkalemia, but the risk of discontinuation of the drug due to hyperkalemia was minimal. If you look at just more details in the renal sort of parameters, there was a 20% reduction in the incidence of ESRD in this broad population, 13,000 patients with a wide spectrum of GFRs and albuminuria. So I think because of this is the draft KDIGO guideline. It's not the final version. This is still under review for treatment of diabetes and chronic kidney disease in 2022, uh, which says that first-line drug therapy from a diabetic, our glucose management perspective is now metformin and SGLT2 inhibitor, and they're going up to eGFR of 20 based on, I guess they expected the EMPA kidney trial to be positive. But there's other data, like for example, in the heart failure world, where they have used it up to a GFR of 20. Then obviously the other component is GLP receptor antagonists. They are, so to say, more effective in lowering glycemic targets. And also they are very effective in weight loss. So depending on the patient, they are an important tool and they can be combined or even initiated earlier depending on the patient. Then for management of hypertension and albuminuria, their first line recommendation is the RAS inhibitor, and then they're recommending now, because of the finerenone data, that non-steroidal the MRAs be added if there is persistent albuminuria. There is no threshold, so any albuminuria. And then obviously other drugs can be used for blood pressure management. In addition to that, other therapies for lipid management or antiplatelets for atherosclerotic cardiovascular disease have to be used to minimize the risk of cardiovascular complications. Uh, Same thing if you look at how hyperglycemia is managed now, the ADA standards now recommend a sort of comorbidity-based approach. So if patients have atherosclerotic cardiovascular disease or indicators of high risk, then either a GLP analog or an SGLT2 inhibitor with proven CVD benefit is first line. And this will depend on, I guess, what their A1Cs are or what their comorbidities are. Like somebody who needs more weight loss, maybe the GLP is the way to go. And it has to be still individualized. For heart failure, the evidence is so strong now that they're just saying SGLT2 inhibitor in everyone. For CKD, we sort of talked about it, that if this is going to change, I think, like already if EMPA kidney is positive, then I think it's going to be SGLT2 inhibitor for everyone, like in heart failure. So this is going to change very quickly. Then in addition to that, so in diabetes, obviously everyone gets at least a moderate intensity statin, and it may be more, depending on their cardiovascular risk. An interesting study just came out because we always say that chronic kidney disease patients are at higher risk for cardiovascular events. And so they used a model from the CRIC study, and they used slightly different parameters than the standard ACC sort of calculator. And they have come up with a model that can be used to predict cardiovascular risk specifically in the CKD population. So that should be interesting when it sort of becomes usable, so to say, or it gets validated in maybe a different population. So moving on, I'm going to talk a little bit about the heart failure data, because I think we are sort of moving to that era where we can't be sort of siloed. We can't just sort of know the CKD data and not worry about the heart failure data. And similarly, the heart failure folks will have to know CKD data a little bit because we have to incorporate their sort of treatments in our patients also. So obviously, I'm not going through every single trial. I'm going to talk about some of the recent trials. And I'm not even talking about all the recent trials. There's too many, and too many positive trials, so to say. So first, I'm going to talk about the angiotensin-neprilysin inhibition, because this comes up very often day to day that, oh, I want to switch your patient with CKD3 from an ACE inhibitor or an ARB to Entresto. So what's the data for that? So this was the big sort of, I could call it game-changing trial for Entresto, or the angiotensin-neprilysin inhibitor. This is called the Paradigm Heart Failure Trial, published in 2014. So it's already 8 years old. It enrolled a lot of patients, followed them for 27 months. One third of them had diabetes. Again, almost 100% of them were on ACE or ARB at baseline. What's interesting to note is that they excluded patients with relatively low blood pressures, and this is pretty common in the heart failure population. So that's important to remember. And they also excluded patients with eGFRs less than 30. What it did show is that the primary outcome, which was basically CV death and hospitalization for heart failure, was reduced by 20%. Now, if you compare an RNA, like why the fuss? Like sometimes I was like in the beginning, like, what's the big deal? Like, why do I need to urgently switch my patient from an ACE inhibitor to Entresto? So if you compare the effect of angiotensin receptor blockers and ACE inhibitors to Entresto, or I'm just using Entresto, but there's only one drug, which is the sacubitril valsartan. It's difficult for me to pronounce it each time. That there's an additional 20% decrease in mortality by making this switch. So that is huge. And that sort of underlies why heart failure doctors are pushing for this on a wide scale level. If you look at renal outcomes, so just the renal outcomes of the paradigm, there was an interesting trend that it did slow the rate of decline in eGFR slightly. Again, if you look at the baseline creatinine, it's only 1.1. So these patients are sort of low risk in terms of progression to ESRD. So even slight change in curve is significant. The other thing to remember is there is some data that the combination of sacubitril valsartan actually increases albuminuria compared to an ACE inhibitor or an ARB. So despite that, the eGFR is sort of declining at a slower rate with this combination. There was a second trial which was done in the HFpEF population. It's called the Paragon Trial. Again, low risk from a renal perspective. It had a substantial number of patients with diabetes. The primary outcome, which was CV death and hospitalization for heart failure, was negative. But interestingly, the composite renal outcome showed a 50% decline in progression of kidney issues. So that's interesting. Now, what I have seen is that a lot of these patients, they actually get their blood pressure lowering effect of this drug is much stronger than an ACE inhibitor or an ARB. And that was pretty much seen in at least the Paradigm trial. If you look at the Paragon trial, they're also having higher episodes of hypertension. So that's something to keep in mind when this, like what their baseline blood pressure is. And, they may require slow up titration or discontinuation of some medicine if the switch is being made. The other thing is that there was no difference in angioedema with this drug. So, we have to be aware that one, it causes hypertension. Now, if you look at, I forgot to mention the sort of rise in creatinine. So does it cause more AKI, so to say, or does it sort of worsen kidney disease? And interestingly, the incidence of worsening kidney disease is lower with the combination as compared to an ACE inhibitor. The third and last trial with this drug I'm going to mention is the Pioneer trial. And the reason for that is this is starting this drug in patients who are admitted to the hospital with decompensated heart failure. So you sort of stabilize them and immediately start them on the combination of sacubitril valsartan. And again, their primary outcome was just the change in BNP because this is a short-term trial. And there's a significant difference between the two groups with the combination causing a more substantial drop. And why, again, why the urgency? Because within like 2 weeks, these curves start to divert. And you can see that there's a substantial reduction in mortality, rehospitalization, or LVAD placement. So that's why everyone's in a rush. And we can talk about it later, what are the limitations of that. If you look at in this trial, there was no real sort of difference in renal outcomes. So they didn't actually even see a lot of difference in hypertensive episodes, just a slight increase. Now, sort of giving a broad overview of all the other trials. The reason I wanted to do this is that it sort of also highlights how clinical practice is evolving. So the RALS is like a 98 trial with spironolactone. Emphasis was again with mineralocorticoid receptor antagonists, in this case, eplerenone. And this was slightly different population because RALS was in the 3 and 4 NYHA class versus emphasis was only in the class 2. And then we have all these newer trials. But as you'll see, over time, the baseline therapy has changed. So while RALS only had 10% people on beta blockers, most of the recent trials have at least 90% people on beta blockers. When you look at ACE inhibitors, the later trials, because these were done sort of 10 years after the data for ACE inhibition became standard of care, they practically had everyone on ACE inhibition. But then when the Paradigm heart failure trial was done, a lot of patients were already on mineralocorticoid receptor antagonists also because of these previous trials. And similarly, that keeps on changing. Now, the most recent, the SGLT2 inhibitor trials, the DAPA heart failure and Emperor reduced, they had a small percentage of people who were on the sacubitril valsartan instead of the ACE inhibitor. So this is despite the evolution in therapy that each of these trials is a positive trial. Each of these has shown significant reduction in hospitalization for heart failure. Each of these trials has shown significant reduction in mortality. I'm going to talk a little bit about these two trials. So before I go to that, the other question that came to my mind is, what happens to blood pressure if we say that, oh, there's more hypotension? Can I use it to treat blood pressure? Like if I have a patient in clinic and now, they have just resistant hypertension. So this was a sort of a post hoc analysis of the second trial, which is the Paragon trial. And what they found is that you did have a better blood pressure control in the patients who were labeled as apparent resistant hypertension, or even apparent mineralocorticoid receptor antagonist resistant hypertension. So there was a stronger blood pressure lowering drug. So I think this needs to be studied more because that may become an interesting therapy for resistant hypertension. Now, comparing the two sort of empagliflozin heart failure trials. So one was in the low EF population, one was in the preserved EF population. Roughly half of the patients had diabetes. As you can see, they're not really sort of high risk renal populations. So maybe half of those patients had CKD, but it's not really CKD4 or anything, it's just mild. And Emperor reduced went to GFR of 20, but the mean GFR is 62. In Emperor Preserve, the mean GFR is 60. So these are not really high-risk renal populations. But when you look at just the renal outcomes, the composite renal outcome was significantly lower in the Emperor Reduced trial. And you do see that GFR dip, but again, as we've seen in all the renal trials, that sort of switches over at some point. What's also important to remember that the follow-up of these trials is very brief, and I'm going to show that later to compare them. When you look at the other trials, so Emperor Reduced did show a benefit in renal outcomes. Emperor Preserved did not show a benefit in renal outcomes, but when you subdivide the EFs, the 40 to 50 range does show a benefit in renal outcomes again, versus the LVF more than 50%. That's the group that didn't show any benefit. The last trial I'll talk about briefly is, again, uh, this is the Soloist trial, which was done with the combined SGLT2 SGLT1 and 2 inhibitor, which is sotagliflozin. The reason I wanted to talk about this is because this is, again, a trial in decompensated heart failure. So patients who are admitted with decompensated heart failure are initiated on an SGLT2 inhibitor. What's remarkable is that this trial was actually stopped because of sort of logistical reasons, because it was being done during the COVID pandemic, but it showed a significant reduction in CV death and hospitalizations for heart failure. These are the sort of adverse events, not huge differences between the two, but what's interesting is if you actually sort of blow up this graph, the graph diverges at 12 days. So you reduce the risk of CV death and hospitalization within 2 weeks of starting an SGLT2 inhibitor. And that's the reason why heart failure specialists are now trying to rapidly implement these therapies. Sort of comparing all these trials that I've talked about. So if you look at EMPA-REG Canvas, which was sort of the early sort of trials on the kidney side, or this one is CV outcome trial, this is the kidney trial, this is the heart failure trials, and these are the more sort of dedicated diabetic kidney disease trials. And you'll see that the GFR change is significant in all these trials. What we forget is that our standard of care so far had less effect than any of these trials. And we are sort of like that sort of given that we have to have patients on these drugs. But I would argue that some of these drugs, especially SGLT2 inhibitors in the Credence and DAPA-CKD, have a much bigger benefit than even the ACE inhibitors because they're being added on. And this is sort of one analysis, which is suggesting if you look at the Credence, sorry, I labeled this wrong, it's actually the Credence trial, that you might gain, if you take the average person in the Credence trial, you may gain additional 15 years freedom from ESRD. And I think that is maybe, the biggest sort of outcome that we could hope for. One or two last words. So this is an interesting paper that just came out that if you look at the DAPA-CKD and DAPA heart failure trials and look at it only at the patients who had pre-diabetes, there was a substantial reduction, like a hazard ratio of 0.67 in the incidence of sort of transition from pre-diabetes to diabetes. So this could sort of lead to sort of further trials that should be, like I showed, there's such a high risk of cardiovascular events, even in the pre-diabetes population. So this begs the question that do we need to start doing a trial in the pre-diabetes population and sort of prevent diabetes onset and prevent cardiovascular events, prevent diabetic kidney disease? I don't think this question is answered, but more to come there. As I mentioned, EMPA Kidney announced last week that they've been stopped. They stopped the trial because of efficacy. FLOW is the last trial that's out of these major trials that is yet to come. That's going to be another couple of years. So the question is, what do we do with this evidence? And we know that since the ACE inhibitors, we've been miserable. Like if you look at certain studies, even checking urine albumins, the incidence of checking albumin to creatinine ratios in the primary care population is abysmal. At best, it's at 40%, 50%. As you may be aware, 2022 is the first year that it's now been introduced as a HEDIS measure. So primary care practices will be judged by what percentage of diabetics are screened for with a creatinine and a UACR. So maybe that will lead to more adoption. I don't know. We'll see. If you look at other sort of use of evidence-based therapy, we are always slow in implementing evidence-based therapy. And in this paper, optimal medical therapy for atherosclerotic cardiovascular disease was being used only in 6 to 7% patients. So there's a lot of gap between evidence and implementation. If you combine, and this is like sort of an interesting thing, that if you combine all the trials that have been done in heart failure, the overall relative risk reduction is 74%. Absolute risk reduction is 26% in mortality. And those are huge numbers. So we have to implement the evidence. This is what's coming up now. So the cardiology world is sort of moving towards rapid implementation, and you'll be probably seeing this a lot. So according to this, guideline-based medical therapy will be implemented within 4 weeks. This is just a recommendation. Obviously, this has to be individualized to patients. So step one, first week, you get started on a beta blocker and SGLT2 inhibitor. A week later, you get started on an angiotensin receptor and neprilysin inhibitor. And the last step, like at 4 weeks, you get started on a mineralocorticoid receptor antagonist. So all four are the pillars of guideline-directed medical therapy for heart failure. And it's being recommended they be started within 4 weeks. And that's why all the new consoles for AKIs, that's going to be happening. This paper just came out a few weeks ago, which sort of stratifies the same thing, but in a slightly different way. So they say that if the GFR is more than 60, just start all four drugs. If the GFR is 30 to 60, then you start 3 drugs, and then you up titrate with early reassessment. It's not like, oh, I'll see you in 3 months. It's a reassessment in a week or 2 weeks. And then obviously, this is the zone which is sort of no evidence. So there's not really good evidence for anything there. But this is an interesting approach, and we might have to come up with something similar. So the question for this audience is, how do we overcome therapeutic inertia in our CKD population? And that's sort of a topic for debate. And I'm going to present some examples of how we could individualize therapy in our clinic. So as we are aware, now we have sort of different things that we can address. So we know that for a heart failure perspective, these are the drugs that have been shown to be beneficial. We know from an albuminuria perspective, these are the drugs that have been shown to reduce albuminuria. Whether this is a valid outcome or not, that's a matter of debate still. For blood pressure management, you have all these other drugs. And then purely for renal protection, we now have evidence of ACE inhibitors, SGLT2 inhibitors, and non-steroidal mineralocorticoid receptor antagonists. So taking a few examples, let's say you have a patient who has heart failure, has a little bit of protein, but not a lot, blood pressure is controlled, GFR is 36, and this is their regimen. Then the question is, what's missing here? So they have heart failure. They have to be on an SGLT2 inhibitor. So even if this patient is coming to the renal clinic, we have to ask the question, why are they not on an SGLT inhibitor? And the other question is, if they have heart failure with the low EF, then they need to be switched to sacubitril valsartan, not just remain on the ACE inhibitor. So both those things have to be discussed, whether it's with the primary care doctor or if they have a heart failure doctor, uh, that has to be addressed. Similarly, if I take a different patient who doesn't have heart failure, has significant amount of protein, blood pressure is controlled, CKD3, and is on this regimen, then at this point again, they cannot be not on an SGLT2 inhibitor. They have to be on an SGLT2 inhibitor. You have to justify why you're not putting them on an SGLT2 inhibitor. If they still have proteinuria despite the SGLT2 inhibitor, then you would add finerenone. Or the opposite, there may be patients who are not candidates for an SGLT2 inhibitor for whatever reason. For example, a person who has an indwelling Foley catheter and has recurrent UTIs, then maybe you would start with finerenone in that patient and not add the SGLT2 inhibitor as first line. If I take a different patient whose blood pressure is high, they don't have heart failure, but they have the same sort of CKD with a lot of protein, then you add the SGLT2 inhibitor, but then the blood pressure is too high and you know that probably this is not going to be enough. Then depending on what they have, you can decide whether they need a diuretic or they need a mineralocorticoid receptor antagonist. It depends what their clinical profile is. And the last patient has heart failure, has well-controlled blood pressure, has CKD4. So now we are reaching sort of the zone where there's less evidence. So they're already on an SGLT2 inhibitor. Now what do you do? So, the data for heart failure is for a mineralocorticoid receptor antagonist like spironolactone or eplerenone, but the blood pressure is already relatively well controlled. So maybe you're not comfortable adding the eplerenone or spironolactone. So you could sort of go out of the box and still add finerenone in this patient. Now, whether you should also switch to ARNI because they did not include patients less than 30, but you could argue that you could consider that. And I have done it in a couple of patients with close monitoring. And we need population level CKD models. Like it can't be just the nephrologist is the expert or the cardiologist is the expert or the endocrinologist is the expert. Every single physician who's managing these patients has to know how to manage them at some level and then use the specialists at other levels. I found this interesting sort of document on the Intermountain Healthcare website. It's a very interesting model that they are using at their population-based level. And that's all I have. Happy to take questions.
That was great, Anip. It was very helpful.
Yeah, that was brilliant. Can you comment, this is Sarah, on the safety profile of SGLT2 inhibitors? I know frequent UTIs are sort of a relative contraindication, but there were some weird complications in the early studies, like with peripheral vascular disease and things like that. What has come out now? Like, are there other patients that we should think twice about starting these medicines on?
So that was in the Canvas trial. I think that's the only trial that showed sort of a signal of increased amputation risk. I don't think any other trial has since shown that. So people are still hesitant to use it in patients who have sort of untreated peripheral vascular disease. I know Dr. Rasuli is on the call. Maybe she has some comments on what she does in her practice.
Yes, thank you. In endocrinology, Sarah, we also, the same way that Dr. Bansal mentioned that we still worried about that amputation signal from Canvas, and you were totally right that the following trial didn't show it. So in patients who have severe PAD, we are hesitant, we don't start it. Otherwise, we feel comfortable to start everybody on SGLT2 unless they have recurrent UTI.
Anip Stu here. A quick comment and then a question. The comment goes to Entresto. Entresto has fairly low dose valsartan, 50 or 100 milligrams, and a lot of people don't tolerate more than that on a daily basis, as opposed to the blood pressure and renal fact, which is 160 to 320. So from a nephrocentric perspective, I'm not sure that valsartan or that Entresto is going to be as helpful. The question goes to what we're getting asked by primary care, and you and I have talked about this, is that a fair number of people have a bump in their creatinine after an SGLT2. And so could you comment on whether that's a good thing, a bad thing, how much of an increase in creatinine the primary care doc should be worried about?
Yeah, that's, so what's interesting is if you read the heart failure literature now, they're saying a bump of 50% is acceptable. Our literature has always said a rise in creatinine for ACE inhibitors of 30%, but they are arguing that these are all hemodynamic changes and not real tubular damage. There's not great data on that. Like, I tried to look up studies that have actually looked at tubular markers. I only found one, and that actually did show that despite the drop in GFR, the tubular markers didn't go up. So, I think the question is, what are you using it for? It's sort of like with the heart failure population, I think you have to be really hard pressed to say, don't give them SGLT2 inhibitor because the creatinine went from 1 to 1.4, for example, or let's say from 1.5 to 2 even. Because ultimately, they are showing that there is long-term benefits. And now I think with the EMPA kidney, it's going to be even more interesting because it's going to be all these non-albuminuric patients. And so that's going to be interesting, like what happens to the renal function in those patients. So I think 50% may be the new acceptable number. That's what I think.
Anip, this is Sophie. At a lot of, I feel like it's still sort of traditional to start somebody on RAS inhibition first, and then SGLT2 within the nephrology community. It looks like even cardiologists are thinking get the SGLT2 on even before RAS inhibition or the sacubitril neprilysin combination. What are your thoughts upon, let's say we've got a patient who is a candidate and doesn't have any contraindications to RAS inhibition? Do you think that we should be moving towards starting an SGLT2 inhibitor prior to our RAS inhibition, or does it really matter? Or should we be trying to sort of get them both on board and then max them out over time?
So I think that's where, the blood pressure comes into play. Like, what is your blood pressure? So if you have a patient whose blood pressure is really borderline, like if it's 110/70, then you're going to be really ginger with your ACE inhibitor or ARB, right? Like, because you're afraid you're going to drop their blood pressure. So in that case, I would argue maybe the SGLT2 inhibitor should go first. Same thing, finerenone could be used in some of those patients where you're afraid that you're going to drop the blood pressure, or like the other patient who has, say, angioedema on an ACE inhibitor. Then, the ACE inhibitor is obviously out of the picture, then the finerenone may be coming in first. So it just depends on the patient. I think, the difference between heart failure alone, like especially the heart failure with reduced ejection fraction, is they tend to not have very high blood pressures. So it's a different population than the CKD alone, or proteinuric CKD, especially where the blood pressure may be the bigger challenge. So depending on what the blood pressure is, you could choose different drugs. Like, for example, same difference, if I'm wondering about adding a mineralocorticoid receptor antagonist, if I've got a relatively low blood pressure, then finerenone is a better choice. Versus if my blood pressure is high, then maybe spironolactone or eplerenone is the better choice. So a lot of individualization still needs to be done. It can't just be an algorithm.
And if I just want to make a comment on all of the kidney-specific trials, SGLT2 were added on a patient who were on RAS inhibition. Like you showed the baseline characteristic of patient, they were 100% on RAS. I mean, we have the same argument for cardioprotective medication of diabetes, which were all added to the background of metformin. So we are now arguing, should metformin stay the same first line, or other medication can be started as a first line? I think you will have the same argument here about RAS inhibition versus SGLT2. You really don't have evidence, if you want to just rely on clinical trial that you have right now, that SGLT2 inhibitor were added on patients who were not on RAS. I mean, I assume they will have the same protection, but the trials were done on people who were on RAS inhibition.
Sure. Ideally, you want both. Ideally, But like in the real world, not everyone tolerates. Like, for example, like somebody may tolerate only a lisinopril dose of 10, and that's the best we can get, because if you increase it further, then the blood pressure goes too low. So in that situation, the question becomes that, would I rather increase the ACE inhibitor to 20 and not give them SGLT2 inhibitors? I don't know the answer to that question. Because then if the blood pressure is too low, then that's the patient who's going to get AKI because you drop their blood pressure with the SGLT2 inhibitor.
Hey, Nip, great talk. Sorry, and if I break up, it's because I'm driving, and I know we're a little over, but I was just curious, you didn't mention too much about diuretics, and, you know, I've been, I guess, more of a comment than a question, but I want to see what you think about this. In the background of all these medicines coming in the last several years and their efficacy, I tend to just look at diuretics differently. I mean, you know, used to think and still currently think that they're, you know, they reduce blood pressure, they reduce proteinuria, they're great drugs, but they're ugly drugs. They cause metabolic syndrome, they remodel the kidney, they jack up the renin-angiotensin-aldosterone system. And so my own practice is, you know, like when you approach a volume overloaded patient, whether inpatient or outpatient, with whether it's diabetes, CKD, heart failure, is get them on all of this stuff first, as opposed to just plugging away with massive doses of diuretics. Because I kind of look at diuretics as like necessary evils and not necessarily great drugs. And I don't know if you've noticed the same thing in your practice. You just kind of are prescribing a little less thiazide and loop. And if that's the right approach, I mean, where do they fit in all this?
Yeah, definitely. I think like one of the biggest things I've seen with SGLT2 inhibitors, which has been surprising, is how much diuretic effect some patients get. Like not everyone, but a lot of these patients do require reduction in diuretic doses if they're on them, or, you know, if they have a little bit of edema, they don't need it once they get started on the SGLT2 inhibitor. So I definitely think that, we are probably going to use less diuretics with these drugs. That's like, you know,
But just to-
ultimately.
Oh, sorry.
You
I
can
was
go
just going to say to make a distinction between loops and thiazides, because thiazides have great cardiovascular mortality shown in patients with essential hypertension, and that they're a different class than the loop.
Yeah,
You know,
but in diabetes, they do cause a little bit of hyperglycemia, right?
yeah, there's
So,
slight hyperglycemia.
Okay, that's all for today. Thank you, everyone.